program in Department of Oncology in King Abdulaziz Medical City in Riyadh. And his talk will be about genetic testing in patients with triple negative or hereditary breast cancer.
Okay, thank you, Jason. Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Najd, for the kind introduction. And my task today is to talk about the germline genetic testing in breast cancer patients. And I have to say this is a big topic to be covered in 20 minutes, but I will try as much as I can to shed some light on the cancer genetic clinic aspects and what we are doing for patients with breast cancer. So this is the typical referral to a cancer genetic clinic. As you can see, 40%, around 40% are breast or ovary cancer. The other 40% is colon, and the rest among other cancer type. But I have to say, in our experience in our clinic, I would say 85% of the referral to our clinic is coming from breast cancer patient, either from the breast surgery or breast oncology or the primary care physician, which is something good for our patients. So the expectations from the cancer genetics is doing the comprehensive genetic assessment that include the family history of the patient and ordering appropriate genetic testing. And after obtaining the appropriate consent and after counseling the patient, we ordered the genetic test, and we have to inform the patient that the result of this genetic test has implications on the patient themselves and in their relatives. And the implications for the patient themselves, it's mainly related to treatment, especially for patients who survive cancer. Also, secondary prevention is important, risk-reducing strategies and reproductive implications option, and the same apply to the relative for the individual with known genetic mutation. So the referral to genetic clinic is underused in most of the country, and this is the data from the United States. Only 34% of patients meet the criteria for testing with ovarian cancer got tested. In breast cancer, it's 26%, but there was a report about increased the rate of testing between the years 2013 and 19. And this was also published in the past through the ASCO copy study, which is a quality improvement project. And they looked for more than 10,000 chart of patients from different practice. And they looked to the documentation of family history and the referral to genetic counselor. And as you can see here in the last graph, there is only 50% of patients who meets the criteria of genetic testing got tested, and less for patients with colorectal cancer. So the message here is a patient with breast cancer should have genetic assessment as a part of their comprehensive genetic evaluation. And also, it's important to know that in cancer genetic, we are not only dealing with cancer risk assessment. Of course, this is one of the main tasks of the clinic, is to identify gene and the risk of the individuals. However, over the last few years, we know that this germline mutation does not imply only on the risk assessment, but these are potential target for targeted therapy. And also we can use them for prognostication and as a predictive tool. And in each patient referred to our clinic, we have our own assessment for that patient, and there is no one size fits all in terms of the genetic testing or the screening or prevention recommendation. One example of the implications of BRCA gene mutation result on patient as a predictive tool was just published in the last ASCO 2 weeks ago. They looked for a good number of patients with stage 1 to stage 4 breast cancer, and they matched them to genetic testing records. And what they looked specifically to about the outcome of those individuals and the survival. And it's interesting that patients with BRCA1 or 2, they have as good or better 3-year survival compared to patients who test negative. This is mainly because of we know the best therapy that you can direct to those patients and evolving of targeted therapy as well in the adjuvant and in the metastatic setting. So when we see a patient in the clinic, there are different things that we keep in mind before just ordering genetic testing. We utilize the risk models that is available online, and we're gonna touch base on that. There are certain testing criteria for each hereditary cancer syndromes. The ethnicity is very important. As we know that certain genetic mutation is predominant in certain ethnicity and population. Clinical judgment, not all the time the patient meets the textbook guideline for testing, but in certain situations we have to use our own judgment. The pathology, for example, the triple negative breast cancer, all of them has to be tested for BRCA mutation. And the important question, well, this will affect the management of the patient. So example of risk assessment tools that we have, it's different, available. Each one of them has its pros and cons. Some of them, it can help you to identify the mutation probability. However, some of them also can help you to identify the mutation probability and at the same time, the breast cancer risk assessment. So there are different genes that is associated with breast cancer. And as you can see here, the BRCA1 and BRCA2 consider the most or highly penetrant mutation. And we mean by highly penetrant, good proportion of patients or individuals who carry this mutation will express the phenotype of cancer at certain point in their life. However, although the most popular is the BRCA gene, we now understand that the other gene beyond BRCA is common in breast cancer. This is a study of more than 100,000 individuals. They included control and patient affected with breast cancer, and they tested some of the gene that has been proposed as a causing agent or causing genes for breast cancer. And as you can see here, it's not only the BRCA gene that is considered a reason for or germline mutation that drive for hereditary breast cancer. We have BAL-B2, we have CHIK2, we have ATM, we have CDH. So there are multiple genes that is associated with breast cancer. And if you just focus your test on BRCA only, you might miss those patients. So the current practice now, or at least what we are using in our clinic, is to do genetic panel rather than focused genetic test on BRCA. This is just to give you some more analysis of this study that was published in the New England Journal of Medicine just a few months ago. And as you can see here, the odds ratio of 1 was considered the cutoff point. But you can see that, you can see there are some genes, especially the BRCA1, BRCA2, BAL-B2, TP53, they have higher odds ratios, mean that they are high-risk gene and they have to be treated accordingly. Most of the data that I just presented is coming from infiltrative ductal carcinoma. What about infiltrative lobular carcinoma? We know it's represent about 10 to 15%. Also, this population were studies, and one important study was published just a few weeks ago in the ASCO 2021 that looked for patients with infiltrative lobular carcinoma, and they were and they looked for their genetic results for certain of the cancer genes that is known to associate with breast cancer. And as you can see here, it's not only BRCA1 or BRCA2, CDH1, CHIK2, and BAL-B2, ATM, all associated. Interestingly enough, the BRCA1 was not as causing genes as BRCA2. So this is an indication that even for patients with invasive lobular carcinoma, still you have to go with a gene panel if the testing is indicated. So there are different guidelines for testing for BRCA gene, but I think we are moving more and more away from sticking to the guidelines because we know from the literature that we are missing some patients by adhering to only guidelines for testing. And we are moving toward more of universal testing for patients with breast cancer. We know now the result of the Olympia study that might impact the use of BRCA gene testing as a part of standard practice in all patients with early stage breast cancer. So in our clinic, it's important to check if the patient meets the guidelines, but I don't put the weight all on the guidelines. I have to look for many other parameters. So having genetic mutation is bad, but it's not the only risk factor. So we know that with age, the chance of cancer becoming more. So in the left side, you can see the breast, and the right side is the ovarian. The risk of developing breast or ovarian cancers comes with age. And this is also important because this is what guides our decision about intervention or surveillance. If you look to the right side, the incidence of ovarian cancer in BRCA2 mutation happen later compared to BRCA1 mutation. And in those populations, sometimes we give the patient time before referring them for prophylactic bilateral serpingioophorectomy compared to the BRCA1, which we know that they tend to have early onset hereditary ovarian cancer. Another important concept is the family history. So having BRCA mutation with positive family history, it depends on the number of individuals. As you can see here, if there's someone with carrying BRCA mutation and there is no history of breast cancer, their risk by age of 70 about 53%. But if they have two family members with breast cancer, their risk increased to 73%, and the same apply to BRCA2 mutation. So what is the risk estimation for risk of the ovarian or breast cancer in BRCA1 and BRCA2? This is the data from a prospective studies that followed more than 6,000 patients with BRCA mutation. And as you can see here, it's a range of incidence between 50 to 85%, and it has to do with the ethnicity and the population studied. One of the common questions that is being asked in the patient in the clinic who already developed breast cancer is their risk of developing secondary breast cancer in the next 20 years. And in this study, it showed that about 35 to 45% of them of BRCA1 and 20 to 33% in BRCA2, they are at high risk of secondary malignancy, and this is important for the secondary prevention. What about other genes? Again, the age is important risk factor, but it's not as high as BRCA1. And as you can see here, the one in green here is the BALB2, which behave like BRCA2. And it's also a factor that we take into account when we consider prophylactic intervention in those individuals. So these are some of the genes that's associated with breast cancer. Some of them, they are following syndromatic patterns. So you will find benign findings in those patients, like patient with Cowden syndrome, patient with BGS syndrome and neurofibromatosis. However, most of our hereditary cancer predisposition syndrome, they don't follow syndromatic pattern. The risk, as you can see here, is more prominent with BRCA1, BRCA2, BALB2, and TP53, and they are contributing significantly to the hereditary breast cancer. Now, special attention to BALB2, as in the last few years, it's gained some attention. It's the abbreviation of, as I have shown you in the previous graph, it behaves like BRCA2 mutation. It's increased the risk of breast, ovarian, and pancreatic cancer. And as you can see here, age is another important factor. So women carrying BALB2 mutation, their risk jump from 17% to 55% by age of 80. Also, this consolidates the concept about the role of family history in someone carrying pathogenic mutation. So as you can see here, those who have a significant family history of breast cancer and they carry BALB2 mutation, they're at higher risk of developing breast cancer. And this is a factor that we take into account when we recommend surveillance or intervention. The same applies to ovarian cancers. And if you look to the pancreatic in male and female or male breast cancer, although it's less common, it goes and increase with the age in this population. So for BALB2 mutation, it's associated with high risk of breast cancer, and I deal with them in the clinic as if I'm dealing with BRCA1 or BRCA2, and they are associated with ovarian, pancreatic, and male breast cancer. We don't have evidence to suggest that they are associated with increase of colon or breast or prostate cancer, and no other overall increased incidence of other cancers. So what we do in the clinic also, once we identify the patient with mutation, we have to apply certain interventions. And as I mentioned, there is no one size that fits all patient. But these are some of the general things that it can be done. So chemo prevention with tamoxifen has been shown to decrease the risk of recurrence by almost 50%. But I have to say this is only applied to patients with BRCA2, only limited patient in one of the studies that looked to the role of tamoxifen as a preventative, they have BRCA2 mutation, but it's an effective method of risk reduction. We know that mastectomy is the most effective method of reducing the risk of recurrence, decrease the incidence of breast cancer among patients with BRCA mutation. However, not every woman accepting this approach. Oophorectomy also is a very effective tool in reduce the risk of ovarian cancer in the right population. The use of birth control pills is associated with reduction in the risk of the ovarian cancer in patients with hereditary breast or ovarian cancer genes. So this is a case study that one of our patients in the clinic, this is a 33-year-old female with no significant past medical or surgical history. She was diagnosed with luminal B left breast cancer in 2019. So this is when she was 31. And she has ER, PR positive tumor, HER2 neu negative with Ki67 of 90%. So high index of proliferation. So she was treated with neoadjuvant chemotherapy, AC protocol, followed by docetaxel until February 2020. Then she had modified radical mastectomy in March of that year, and her final pathology showed T2N1 disease. Then she had adjuvant radiation that was completed in July 2020. Then she has been on tamoxifen and LHRH since that time. So she was referred to our clinic for genetic assessment. So this is a patient that has no family history of breast or ovarian cancer, and she has no other cancer in her family, and she has 9 siblings. All of them are healthy. So one of the things that we do in our clinic is considering the age as important factor. So this is really a young woman to have high-grade breast cancer. So we order for this reason the comprehensive genetic panel for this patient. And it came to show that the patient carry a pathogenic mutation in BRIB1 gene. So the BRIB1 gene is a tumor suppressor gene that interact with BRCA1 gene, and it's involved in the homologous recombination pathway, which is an important DNA repairing mechanism. And the pathogenic mutation in BRIB1 increase the chance about 10% of ovarian cancer. Some data showed that it might increase the risk of breast cancer, and there is no clear association with colon cancer or other malignancies. And if we go back to the large paper that I just discussed, and you can see here the BRIB1, the risk is really not significant for breast cancer. In this study that looked for the role of BRIB1 gene as a part of ovarian cancer was more prominent. And in 30 patients who carry BRIB1 gene mutation, 25 of them, they were having high-grade serous cancer of the ovary. So the evidence is more for ovarian cancer, but there is less evidence for breast cancer. And if you look to the NCCN guideline, there is no evidence, the evidence to support any sort of intervention in terms of intensive surveillance by imaging or risk reduction intervention is not there. However, for the ovarian cancer, the evidence is strong, and they recommend for risk reduction strategies. However, how we can manage our patient that we have. So this is one of the common scenario that we face in the clinic. There is no really significant evidence to support specific intervention. What we do usually is dealing with the patient as a special case and address every aspect. So this patient already developed breast cancer with high grade at early stage. She already in tamoxifen, which we consider it can reduce the risk of breast cancer and the recurrence of breast cancer. The most evidence is for ovarian cancer, so we refer to the gynae oncology, and she
sharing.